All right, guys, so holidays are over. It's now January. It's time to get back into doing some more MEC Minutes. And this month we're going to talk about not to miss electrocardiograms. Another way to say it is, these EKGs don't look right. They look funny. Maybe this is important. Maybe this isn't. So we're going to talk about 4 or 5 different things you'll see on electrocardiograms, or you may see on electrocardiograms, that are important, indicative of things that you can't miss, and that I think you should really pay attention to. So we're going to start with some clinical scenarios. The first is a 21-year-old male who was playing basketball, and he felt dizzy, lightheaded, and almost passed out. He has no history of chronic illness. He has no chronic medications. But with further discussion, you find out that his brother passed away from witnessed cardiac arrest, also while playing sports. So take a look at this electrocardiogram. Take a moment to look at the 12 lead. Particularly pay attention to V1 through V3. And just kind of keep this in your mind as we talk. We'll look at the same electrocardiogram at the end of the conversation and review the high points. So I'm going to pause for like 4 or 5 seconds and let you take a look at V1 through V3. All right, we're going to move on to the second patient. This is a 40-year-old male with exertional crushing chest pain. It's been present for the past 2 hours. He denies any chronic illness. He's not on any chronic medications, and prior to your arrival, there have been no medications taken or administered. Again, there are some changes on this EKG. Take a close look at leads V1 through V3 again, and I'll take a pause so you can take a good look at them, and we'll review this one at the end as well. Okay, our third of 4 patients. This is a 70-year-old male. You're called because of chest pain. He has a history of pacemaker, and this is the 12 lead that you obtained. So when you look at this, keep in mind that a standard pacemaker, the electrocardiogram with pacemaker firing, the electrocardiogram looks similar or identical to somebody with a left bundle branch block. So we're going to use this 12 lead as an example of a paced rhythm, or a rhythm that has a left bundle branch block to it. Again, it's really obvious, but please take a look at leads V2, V3, as well as AVR, and just kind of take a picture in your mind. Finally, the last patient we have for review is a 48-year-old male, or a 40-year-old male with exertional chest pain. Lasted for about 2 hours, but with time the pain went away, and he has no chronic illness, no chronic medications, and when you arrived, you obtained the 12-lead electrocardiogram, which you see here. Again, it has to do with the anterior chest lead, so take a look at leads V1 through V3. Okay, so why are we talking about this? Well, we're talking about this because there are electrocardiogram changes that are not common, but when present could indicate a threat to the patient's health and well-being, and could represent an acute cardiac event. We're going to talk about 4 clinical syndromes or abnormalities of electrocardiograms. I think it's pertinent to point out that all of these have been identified and promoted over the past 20, maybe 25 years. So for older physicians like me, these conditions were really not recognized while we were training. And these are new additions to the knowledge base of our physicians coming out of training. So we're going to talk about Wellens syndrome. We're going to talk about de Winter's T-wave changes. We're going to talk about Sgarbossa criteria for diagnosing an MI in a patient who's got left bundle branch block or paced rhythm. And we're going to talk about Brugada syndrome, which tends to be a genetic conduction defect of the heart, at high risk for sudden cardiac death. And so it's a problem that's only been identified, I think, since 1992. So it's relatively new in terms of what we're aware of as cardiac events that can harm our patients. We'll start with Wellens syndrome. Wellens syndrome has to do with changes across the precordium that are suggestive of subacute occlusion of the left anterior descending artery. These patients tend to progress to an acute MI within days to weeks. Generally, there are no precordial Q waves. There is a recent history of angina, and the pattern can be present when the patient is pain-free. I think it's also important to realize that sometimes these changes can be present and then go away. So if you obtain a 12 lead in the field, it's important for us to look at it because you may have changes on that 12 lead that we don't have on the 12 lead at the hospital. There are two categories or types of Wellens, and they tend to evolve from type A to type B. Type A is Wellens is biphasic T waves in V2 and V3. Don't worry, I've got pictures on the next slide. And then type B, which represents about 25% of the patients with Wellens syndrome, or with ECG changes consistent with Wellens syndrome, have deeply inverted T waves in V2 and V3, and they're really inverted and steep and deep. They're not little minor inversion of the T waves. With time, type A tends to evolve to type B, and all of these changes eventually could result in a STEMI where the patient's having these prodromal symptoms with subacute occlusion of the LAD, and then at some point they have this acute infarct, acute full occlusion of the LAD, and they present with a STEMI. So Wellens syndrome is considered a harbinger of bad things to happen in the future if we don't act timely. So these are the two different waveforms for type A and type B. Type A, again, is about 25% of the patients. And these tend to have the biphasic P waves, or T waves, where you have an upward going T wave and then a downward going. This is one of those circumstances where you look at it, you go, I know this isn't right. So, do you need to exactly remember that this is a Wellens type A? I'm less concerned with that than you recognize that, hey, this is a biphasic T wave, and this represents a problem for my patient. Wellens type B, again, is 75% of the patients. It's got the deeply inverted T waves. They are pretty deep and pretty long and skinny. I think they're pretty obvious when you see them. So that's a Wellens type B. Here's a full 12 lead electrocardiogram. If you look at it, you'll see that the patient's got this upward going T wave, and then it drops down to a negative T wave. So it's a biphasic, goes up, then goes down. So you can see the two components to it here, the upward phase and the downward phase. This is the Wellens type A. Again, if you forget it's a Wellens A, just remember this is a biphasic T wave. Emergency physicians and cardiologists know what that means. That means trouble. Here's a patient with a Wellens B, and here the T waves are inverted and deep. Again, these are pretty obvious, and they go all the way across the precordium from V2 to V6 in this 12 lead. I think if you see those, you'll recognize that this patient's got a problem. So if we don't have a previous electrocardiogram for comparison, we will assume this represents an acute ischemic event until proven otherwise. So here's this also. There's a second deep T wave here that's really going down, and it's really steep and really deep. Let's talk a little bit about De Winter T waves. The Winter T wave is considered a STEMI equivalent. So this is not a harbinger of bad things. This is a bad thing. So when you see a patient with a De Winter T wave, it's suggestive of an acute anterior MI. It's considered a STEMI equivalent. It can present without obvious ST elevation. It's present in about 2% of the patients who have an acute occlusion of the left anterior descending artery. Again, that's a bad artery to occlude, and these patients typically have active chest pain and other symptoms to go along with their acute infarct. As I mentioned, these changes are often are new in terms of medical knowledge. The De Winter T wave was first published in New England Journal of Medicine in 2008. So if you're looking at the T wave criteria, this is lead V3 of a patient with the De Winter T wave. The De Winter T waves have this tall, prominent T waves in the precordial lead. So if you look, it's almost like the exact opposite of a Wellens type B. I mean, these are peaked and steep. When I see these, I think of either De Winter T waves or hyperkalemia. The one way I'll help discriminate that is there also is some precordial ST depression with an upsloping ST segment. So if you look at at the ST segment and the so-called J point, it is depressed, and then it has this gradual upsloping ST segment that goes into the peaked T wave. So if you looked at those two arrows and you look at that, this is more suggestive of that de Winter T wave than a patient with hyperkalemia. And typically there's absence of ST elevation in the precordial leads. So if there is ST elevation, then it's considered a STEMI. But this is a ST depression with that sloping upward ST segment and the very peaked and tall T waves. And you may also see ST elevation in AVR. Most of us don't even bother to look at AVR in a 12 lead, but when you're thinking about the winter, if you see these changes in V3, take a look at AVR and see if there's ST elevation. So another comment is just that STEMI morphology can precede or follow a de Winter pattern. So the patient could have what appears to be a STEMI, you repeat the 12 lead, and then they have de Winter changes, and then you do a 30 kg, and they could be back showing a STEMI again. So these things are considered equivalent in terms of evidence of an acute infarct. These patients need to go to the cath lab for intervention. Here's a 12 lead as an example. So if you look at this, you can look and you can see that the patient's got these tall peaked T waves in leads V2, V3, even V4, and maybe V5. And they also have that ST depression with the upward sloping of the ST segment that you can see here with that second arrow. But I think you should also look at AVR. So here's AVR. If you look at AVR, that ST segment is up a little bit. Is it really pronounced like you would expect to see with an acute STEMI in leads V1, V2, or AV, or leads 3 or AVF? No, it tends to be more subtle, but you can see some ST depression. And I have a second EKG coming up that shows it even more prominently. But this is these are de Winter changes. Here's that other EKG I told you about. So again, if you look at leads V1, V2, V3, V4, you see the ST depression with the upward sloping ST segment and the tall peaked T waves. You see that right there. But again, look at AVR. Now AVR in this 12 lead, the ST elevation is much more obvious. So this goes along with the first slide on de Winters, where we talk about you see elevated ST segment on AVR. So again, you look at this and you go, I know this isn't right. There's something wrong with this. You can use this as part of your report. Hey, I got a patient coming in with active chest pain. They've got ST elevation AVR. They've got ST depression anteriorly with peak T waves. That speaks to de Winter. The ED docs and cardiologist will pick up on that. Let's talk a little bit about MI and left bundle branch block. So, one of the first questions is, does an acute left bundle branch block represent a STEMI equivalent? Years ago, or not that long ago, we would consider an acute left bundle to be a STEMI equivalent. The patients go to the cath lab. Recent recommendations through American Heart have changed that, so left bundle is no longer seen as a STEMI equivalent. There have been some studies out there looking at this. There was a report of 4 studies that were aggregated into one study or one analysis. This is called meta-analysis, where researchers take in data from multiple studies, aggregate the data, and then make conclusions based on the aggregated data. And in these 4 studies, when they're aggregated, it looked like about 40% of new left bundle branch blocks have a culprit lesion on cath, meaning they have an acute occlusion that needs to be opened. But if you look at the range in these 4 studies, anywhere from 7% of left bundles in one study to as high as 61% in another study, where left bundles represent an acute STEMI. And these were patients who had documented newly acute left bundle branch blocks. So keeping that in mind, I think we have to ask, is there a way to diagnose an acute MI on a 12-lead ECG in a patient with left bundle branch? So it's not the question of, does an acute left bundle represent a STEMI, but if the patient has a left bundle pattern or a pacemaker present. Is there something we can look at to see if the patient has an acute infarct or may need to go to the cath lab? And the answer is yes. It's the Sgarbossa criteria. Dr. Sgarbossa, she's a cardiologist, and about 20 years ago came up with these criteria to look at left bundle branch block and determine if there is a STEMI. So I've got a couple slides. The first slide is to talk about the criteria, and here it is. Don't get lost in all the details, because the next slide I think should help illustrate it. But there are three basic criteria. The first and the one that's the most important is if the ST segment is elevated in the same leads where the predominant force of the QRS is upwards. So if you have an upwards going QRS with bundle branch and the ST segment is elevated in the same direction, that's highly indicative of a STEMI. The second criteria is if there is ST depression present in the same direction as the QRS, if the QRS is downward going. And the third is if you have ST elevation that is going in different directions than the main force of the QRS, and that ST elevation is more than 5 millimeters or more than 5 small boxes on the EKG, that is suggestive of an infarct, and that's worth 2 points. So the first criteria is worth 5 points if present, the second is worth 3 points, and the third is worth 2. There has been some modification of this last element where instead of 5 millimeters, it's changed to the ST elevation is more than 25% of the previous QRS or previous S wave. So any score of greater than or equal to 3 has a 90% specificity for MI. So if it is present, it is very specific for infarct. However, most people with infarcts and left bundle branch block don't see this, so you can't use this as saying it's a very sensitive indicator, because it's not very common, but when it is present, it is very accurate. So again, here are the graphs. So if you look on the left-hand side, there's typically with left bundle branch block or paced rhythm, the main vector for QRS is in the opposite direction of the T wave that's typically going in a different direction. So if you look at example A on the left, the QRS, it's widened, it's greater than 0.12 milliseconds, but it's upward going, and the ST segment and the T wave is inverted and downward going. That's the normal pattern for left bundle branch block. In example B on the same on the left, you have the opposite effect. You have a downward going QRS and an upward going T wave with some ST changes. That is what you expect to see on a patient with bundle branch block. If you look at Sgarbossa's criteria on the right-hand side, there are 3 different QRS forms there. That first one on the left, you have an upward going QRS, and the ST segment as well as the T wave are upward going. So this is called concurrent or concordant alignment or deviation. So this is highly suggestive of a patient having an infarct. It's highly sensitive, and it's worth 5 points, and this patient probably should go to the cath lab. If you look at the one in the middle, actually go all the one far on the right. The one on the far right is worth 3 points, and this is for that circumstance where you have a QRS that's going downwards mostly, and you have ST depression downwards. So that is the second criterion for Sgarbossa, and that's where there's concurrent ST depression with the direction of the QRS. So you have a large S wave, it's downward, and that S wave makes up the majority of the QRS direction, and you have ST depression to go with it. Then finally in the middle we have this one's worth 2 points. That's where you have a deep S wave. It's widened as part of the bundle branch, but then you also have ST elevation that's greater than 5 millimeters. That's the original criterion put out by Sgarbossa. It's been modified so that it's more than 25% of the length of the S wave. So looking at this one, it looks like it's about 6 or 7 millimeters, with the total S wave being about 18 millimeters. So 7 out of 18 is much more than 25%. Hopefully that makes sense, but I will show you on the next slide here. But keep in mind, these are things, again, if you look at it, you don't need to know whether it's Sgarbossa that's worth 5 because they have concordant direction of the QRS and the T wave. If you have both going the same direction and the ST segment's elevated, that is highly suggestive of an infarct. This one is a paced patient. If you look at this patient, he's got a pacemaker in place. You can see the pacemaker spikes, but it represents a left bundle branch pattern. If you look at it, you have this ST depression that's in the same direction as the S wave. This is worth 3 points, so this is highly suggestive of a patient with an infarct. If you look at this 12 lead, you have another patient with a bundle branch block, and we always look at the QRS and V1 through V6, but take a look at the inferior leads. If you look at the inferior leads here, you actually have a downward going QRS, and you have the ST elevation, and this is worth 5 points. So this is a case where you've got the majority of the QRS is upward going, and you also have ST elevation. If you look at lead 2, it's even more obvious. You can see that there's an upward going QRS, but there's also an upward going T wave, and the ST elevation is present there as well. So I just want you to be comfortable and look at that and review it. The last thing I want to talk about is Brugada syndrome. This was first diagnosed, maybe 27 years ago, first published by the Brugada brothers. They're cardiologists. This represents a condition where the patient's at risk to develop a life-threatening ventricular arrhythmia, and it is something that can be inherited, so genetics are important. These patients are at high risk for cardiac arrest, even though they have structurally normal hearts. So it's a problem with the electrical conduction system of the heart. Undiagnosed, it has a mortality of about 10% per year. I'm not sure exactly at what age the 10% clock starts ticking, but I suspect it's more likely teenagers and adults. People who are native to Southeast Asia or whose family come from Southeast Asia are at the highest risk for this. Males are more likely to have it than females. The syndrome itself is based on abnormal ECG findings and clinical criteria, and we'll talk about those in a few minutes. Something to keep in mind is that the ECG criteria may be transient, and they can be unmasked by things like fever, cardiac ischemia, certain medications, hypokalemia, or hypothermia. I think my most important point here is ECG criteria can be transient. So if you have a patient with symptoms of an arrhythmia, it's important to get that 12 lead because you may capture these EKG changes that are not present in the emergency department. There are some symptoms that go along with the syndrome, and you have to keep in mind that the syndrome itself is based upon ECG findings and clinical criteria, but symptoms that are commonly associated with this are dizziness, fainting, gasping or labored breathing, especially at night. So sometimes family members will say that, Dad's making these funny breathing noises at night. Patients can have palpitations, and patients can have cardiac arrest. So if you look at these symptoms, a lot of them are symptoms that we see on a regular basis, and we kind of wonder about how important they are. Let's talk for a slide or two on the changes that you can see on electrocardiogram. These are ST changes, ST wave changes that you see in the anterior chest leads, typically V1, V2, maybe V3. And there are 3 types, and the only type that is truly considered diagnostic is type 1. You see coved ST elevation with the elevation more than 2 millimeters, and it's in 2 or more anterior chest leads. I had down V1 through V2. It should actually be V1 through V3. And so they have these coved ST elevations, and those elevations are immediately followed by an inverted or negative T wave. I'll show you a slide. It's pretty obvious. Type 2 is you'll see more than 2 millimeters of ST elevation, and it's got that saddleback appearance, but there's no inverted T wave. And then type 3 is basically a type 1 or type 2, but there's less than 2 millimeters of ST elevation. So again, type 2 and type 3 are non-diagnostic, but do warrant further evaluation, particularly if the patient has symptoms. So here are the different types. So I mentioned type 1, type 2, and type 3. Type 1 has the ST elevation. It's got a little bit of a saddleback appearance, and then it goes from that to T wave inversion. So you can see that change. This is a type 2. It's got a typical saddleback appearance, and so you've got the saddleback appearance, but there is no inverted or negative T wave. And then type 3, it's basically this version looks like a type 2, but does not have the 2 millimeters or more of ST elevation. So again, we have type 1, type 2, type 3. If you look at them, it's this just doesn't look right. This patient needs further assessment. I'd be happy if you can remember all 3 types, but to me it's more important you recognize that this is not normal. This could be a problem for the patient. Establishing a diagnosis of Brugada's. So this is the syndrome. This is not the EKG changes. This is the syndrome. Type 1 change on an ECG plus one or more that you'll see, which could be a documented episode of VFib or VTAC, a family history of sudden cardiac death at less than age 45 years of age. These COVE type ECGs can be seen in family members. So if you have a patient with a type 1 ST T wave change on EKG, and family members have abnormal ST segments in these leads, then you can establish a diagnosis of Brugada. In some cases, electrophysiologic cardiologists take the patient's cath lab, they'll try to cause the VT or can cause VT with electrical stimulation. That is considered to be a diagnostic indicator of Brugada if the ECG is also abnormal. Or patients who have any reported syncope or nocturnal abnormal respirations, they will be then considered to be part of Brugada. The treatment for Brugada is occasionally medications, but usually if the patient's diagnosed with the Brugada syndrome, they get a prophylactic placement of an AICD because these patients are at high risk for VF arrest and sudden cardiac death. So we've been through the EKG changes. Let's talk a little bit about, or go back to those original cases. So we just talked about Brugada. I set it up for this patient. Here's a patient who's 21-year-old. He's got no chronic illness. He felt dizzy and lightheaded while playing basketball, and his brother suffered a cardiac arrest. If you look at his 12-lead EKG, he's got Brugada type 1 ST changes present. So he is a patient who meets diagnostic criteria for a Brugada syndrome because he's got the type 1 changes and symptoms of syncope and a family history of cardiac arrest. So this patient's a high-risk patient. This patient needs transport and needs to be assessed by a cardiologist. Here's a patient, again, exertional crushing chest pain for 2 hours, no chronic illness, no treatment prior to arrival. What's the abnormality? I kept referring you to leads V1 through V3. If you look at this patient, he's got the ST depression with that upward sloping ST segment and the peaked T waves. He's got the winter changes. This is considered a STEMI equivalent. This patient needs to go to the cath lab. Patient number 3, 70-year-old, he's got a pacemaker. The question is he somebody who's got a STEMI or a STEMI equivalent? Does he need to go to the cath lab? So again, if you look at his 12 lead, he's got that ST depression going in the same direction as the majority of the QRS, or in the same direction as the S wave. So he gets 3 points based on Sgarbossa's criteria, and he should go to the cath lab. There are those changes. Finally, the last patient that we had was a 40-year-old with crushing chest pain. I believe I said he had no chest pain at the time that you got there. He's on no meds, no chronic illness, and he has not had any treatment. Again, look at leads V1 through V3. He's got that biphasic T wave, so he's got a problem. He's got Wellens type A. And this is highly suggestive of impending occlusion of the left anterior descending artery. High-risk patient. So bottom line, some closing comments. The EKGs that we talked about may not be common, but they represent real risk to our patients. And as we evolve as clinicians, I think you need to be aware of these conditions and at least have the ability to recognize that something's not right if you can't remember the exact terminology that I've used today. If you don't remember the names, remember the ECG abnormalities are not normal. Be able to describe the abnormality. Sometimes we're better, things are better if we describe the abnormality than if we try to put a name on it. So the patient's got, biphasic T waves. Patient's got tall peaked T waves with depressed J point and upslope of the ST segment. Patient's got left bundle branch block with concordant ST elevation or depression, depending on whether he's got a big R wave or a big S wave with concordance. And then finally, you really can't do too many 12 leads in the field. Always think about Brugada in athletes with syncope, dizziness, or altered LOC. Always do those 12 leads and bring them with you, broadcast them to the hospital so that we can consider them as part of our medical decision making with the patient. So that's all I have for January. Thank you. I hope I didn't confuse you, particularly over the Sgarbossa criteria. Feel free to post your questions on Workplace. And if you have an interest and want more information, I'd be glad to get back with you on a one-to-one basis to talk about the questions you may have. Thank you.